welcome to Moroff. My name is Dorothy Mowbray. I'm on the board of directors here and also chair of the media committee. And this Moroff is all about being a resource group to the medical community, and we're so glad that we can provide such great information in these kind of presentations. If you ever have wondered what else we've talked about or had a pressing question on things, please be sure to check out our website at moroff.net. We also have a YouTube channel, so every one of our previous presentations have been recorded, and you can go there and see the video and get questions answered on a variety of different healthcare topics related to the business of healthcare. So please encourage you to go to all those resources that have been there. And today's topic is going to be closing healthcare gaps, how health risk assessments can improve patient outcomes and practice profitability. I think those are two benefits that anyone in healthcare would definitely want to see, because I'm sure many of you got into healthcare to have results with your patients, and obviously, practice profitability keeps you in business so that you can help more people, so it's a good roundabout way. Our presentation is done by Dr. Maulik Shah. He is going to discuss the role of risk assessment tools for more accurate identification of healthcare gaps and methods to implement precision medicine initiatives in a medical practice. Dr. Shah is an internist and a clinical geneticist and a thought leader in precision medicine. He has an MD and a PhD degree from Medical College of Virginia. Dr. Shah is the medical director for Genetic Medicine Clinic and Welltality Health and the managing director of GenomeGyde. He is also a faculty member at UCF, UF, and City College. So he has more accolades than we have time to talk about, let's just say. So without any further ado, Dr. Shah.
Thank you very much. Thank you. Thank you, Connie, for inviting me to come speak at this forum. This is actually my second time, I believe, coming. I had to drive from Gainesville, so if I'm a little discombobulated, please forgive me. So today we're going to talk about closing healthcare gaps. And when I came up with the title, it's a really good scientific title, right? Because it's very specific, but it's not very sexy. It's it's not very much fun for the most part. And I realized while I was putting this together, it's because we're focused very narrowly, on the trees rather than the forest. So I'm going to start this and talk about the forest and then narrow it down a little bit. I do have some disclosures that I should say. Some of the stuff I'm going to talk about today, I do receive either financial compensation or am involved in some way in ownership of the companies. Currently, I'm head of research for a German company that does medical diagnostics. I own a molecular diagnostics company, GenomeGyde, which we'll talk about a little bit later if we have time. I'm the medical director for Welltality Health, and my colleague, Ellen, you might have met in the back. And this is where we're going to spend a bunch of time today. And I'm the medical director for Precision Medicine Clinic. And then I'm on the board of a whole bunch of other things, which is not important, but just so you know. So as one of these affiliations with University of Florida, I'm the director of global health, and so I run medical mission trips to South America with UF medical students. And so I've been very involved in global health for a whole number of years. My younger brother is part of the global health program at Johns Hopkins, and so I've actually developed some diagnostic tests that he uses in Nigeria and Bangladesh in the field of HIV. But I've been involved in global health for quite a while. This is me actually last month heading into the middle of the rainforest in Ecuador on the Ecuadorian-Colombian border to see a number of indigenous people over there. So I think about healthcare from a global perspective as well as from a very specific perspective in our daily practice. But when we think about global health, and this is where this concept of closing healthcare gaps becomes important. If you look at what's happened in terms of income gaps across the world from 1990 to 2011, right? The U.S., we have a lot of high income, upper middle, lower income over here. And then when we think about where the healthcare needs are from the World Health Organization standpoint, it was mostly this 3.1 billion people that fall into low economic or socioeconomically deprived areas, right? This is where, come on, we see the nonprofits that tug at our heartstrings with the poor children who are, starving or don't have clean water, et cetera. But globalization has happened, right? So with globalization, what's happened is that low-income gap is actually much smaller, and then this is much bigger. So when you go to Ecuador, when you go to any of these other countries, there's a much higher percentage of people that are in this lower middle income, upper middle income bracket. Why is that important? Because the healthcare needs change and become different. So when we think about what the world was like, you can take two countries. So this red is China, and this is blue is Sweden. And so a couple hundred years ago, it didn't matter if you were born in Sweden or China. The odds of you dying before age 5 were pretty good, right? And then places like Sweden got a lot better, right? For a whole variety of reasons, from political, economic, access, policy, right? And Sweden's a great place, and so the gap at one point, when we talk about the early 1900s, was the highest it ever was. And when we still think of global health, we think about the gap, right? Like we're still thinking about those poor children in Africa that we see, or we're thinking about the UNICEF commercial. But you can see that there's a convergence going on, and so the risks now of dying if you're a child in China or the US or Sweden is about the same. This is well illustrated by what happened in Rwanda, right? So Rwanda, when you take, what is that, 1997, so around the year I graduated medical school, your odds of dying were tremendous if you were in Rwanda. But if you look, right, they managed to get their political situation taken care of, and Rwandans actually have a pretty good infrastructure for healthcare, et cetera, which we may not believe because we have a very biased view of it. But if you look at what's happened to their child mortality rates, right, their child mortality rates is actually better than most of other sub-Saharan Africa. It is on pace with the world. In fact, if you're African American in a lower socioeconomic demographic in the US, your odds of dying before age 5 are greater than if you are a Rwandan child, okay, which should be somewhat embarrassing to us. But the whole point of this is there's this massive convergence going on. And if you look at World Health Organization data, this convergence is probably going to happen around 2035. And so what does that mean with this convergence? It means that those things that result in child mortality, et cetera, will come to about the same. And so globalization in healthcare will have happened. And so with that, it means the healthcare issues are going to be different, right? So if we think about what are the healthcare challenges coming up, right? So this is where a lot of global health was focused. When you think about the Gates Foundation, et cetera, right? Which is averting infant, child deaths, maternal deaths. And there'll always be somewhat of an unfinished agenda, but it's not going to be nearly as important moving forward. The emerging agenda is towards non-communicable diseases, right? And this shift in disease burden is going to happen everywhere. And this shift in disease burden is going to be chronic diseases, hypertension, diabetes, et cetera. And so we're faced with this problem that this emerging agenda is not going to only impact us, but impact the whole world for the most part. And so setting up systems to address that will be an issue. And then most importantly, as you saw that big demographic shift of people in the lower middle income and upper middle income, there's going to be cost issues, right? So part of the solution is not just going to be on the healthcare side, but it's going to be on the associated mechanisms of how we pay for this healthcare, right? This is part of obviously an ongoing debate here in terms of what to do for this. So now moving from the global perspective, let's move to the community perspective, right? So we all want healthy communities, right? I think many of you here are probably somehow involved in making Orange County more healthy and involved in various initiatives to that, right? So this is the picture you always see, like 3 generations having a nice, picnic together. the reality is this boy would be on an iPad, I'd be sniping at my wife, the grandparents would be, clueless, but this is what we're hoping to have happen in our backyard. No mosquitoes and gnats killing us for the most part. So how do you build healthy communities? So if we take this global healthcare perspective, how do you build healthy communities? And to build healthy communities, there's not a single right answer, but it takes a collective vision of a lot of people. And I think many of you here are probably involved, obviously, with healthcare providers, some of you in the public health spectrum. We're actually people that live in communities, yes, and then we have various businesses that interact. Some of you may be involved in this insurance side. So there's a lot of pieces that have to come together to put together a collective vision or focus for developing a healthy community. And then what do you need to have a healthy community? I'm sorry if you can't read this, but this is a general blueprint, and it says access to recreation and open space, access to healthy foods, access to medical services, access to public transport, access to quality, affordable housing, access to economic opportunity, right? So these are other things that are just as important to having a healthy community as taking care of the patient with hypertension. And I won't go through all of this, but you know who does these kind of things very well? If you look at all the countries that are on that list of the world's happiest countries, right? They're all Scandinavian, but they do all of these things very well. So if you take like a Sweden, a Finland, a Norway, a Denmark, even a Canada, they tend to do these things very well. And so it really has to be a partnership to come up with this. So now from building a healthy community, a big part of that is having healthy people in the community. So I'm going to give you a question. So are you healthy? Who here thinks they're pretty healthy? Okay, tell me why. Why do you think you're healthy?
I don't have pain.
Okay, so no pain, that's a good one. How about you?
I feel well, no pain.
Okay, so your general state of health, you think you're healthy. Anyone else, why do you think you're healthy?
Great genes.
Oh, good genes, right. That's a good one, and something we're going to talk about. And so genes gets into your perception of health, right? Because you're essentially saying my perception of my health is better because I've inherited something that is going to prevent disease. Because you're not thinking about it. You're not necessarily focused on it, right? So a lot of what we've talked about is absence of disease, inherent factors due to health. So, but the problem is when you think about absence of disease, it doesn't necessarily mean you're healthy, right? So if anyone watches The Biggest Loser, there's this guy who was a trainer on it, and we would all agree that he's probably one of the healthiest people in America, right? And he had a heart attack at age 52, right? Patrick Swayze, I wish I had his abs. Died of pancreatic cancer at age 50 something, right? So how do you know sitting here that you're healthy, right? So the absence of disease doesn't necessarily mean there's no possible development of disease, right? So if I gave the same talk 10 years from now, right, and we had the same people, right, we might have a very different perspective, because our 10-year risk for disease is very different. Your 10-year risk for heart disease is very different from your 10-year risk of heart disease, let's say. And sitting here, we don't know that. So sitting here, and because we feel well and we're not focused necessarily on our health, doesn't necessarily mean we are healthy, right? So that brings up the question of not only what constitutes health, but how do you know you're healthy, right? Like, how do we know sitting here that we're healthy and that I'm not going to develop cancer next year, or that I'm not going to have a heart attack, at my next lecture, or when my, kids have to have braces and I see the bill. And then fundamentally that leads to what makes some people healthy or not, right? because I would think that guy from Biggest Loser is healthier than I. If I just had to compare us, based on very limited information, right? I'd say, yeah, I'd put my bet on that guy before I put my bet on myself, because I like my beer a little too much and, wings and etc. But the reality is I'm pretty close to his age and I haven't had a heart attack. So, I am healthier. So the question is, what makes some people healthy and others not healthy? And so if we think about the determinants of health, and sorry, the parts didn't come out, there's actually a lot more than our individual perceptions of health. There's policy making, makes up a small percentage. And policy making is, do we tax alcohol? Do we tax tobacco, right? Tobacco rates have gone down tremendously. And with it, there's been a decrease in like lung cancer, et cetera. That's all government policy making, right? Putting big, skull and bones on tobacco and taxing it. One of the reasons there's very little obesity in Norway is if you've ever tried to buy a soda in Norway, it costs about $7 at the grocery store, right? So you're less likely to buy a Pepsi. You might buy a beer instead because it's a lot cheaper, but that's a different question. But once again, no empty calories results in it. So policy making is actually a big determinant of individual health for the most part. And part of that is also, access, et cetera. Social factors. Where you live, right? We talked about having access to green, healthy spaces, all of those other things. But this is kind of also transportation, right? Do you have the ability to make it to your doctor? How many of us know elderly folks that, only go to the doctor once every so often because they just can't make it. It's too difficult. They can't walk. They can't do it. So social factors. Individual behavior, which is where we're going to spend a bunch of time, and this is where we talked about where everyone gave examples, right? Where it was the fact that I don't smoke, that I feel healthy, I'm not focused on it. So individual behavior is actually the easiest thing to impact, right? But it's hard to impact policy making because I've never met a politician that actually listens to what should be done. But individual behavior can be done. And then health services is another area that we can actually improve, right? How we deliver healthcare services to do this. And then, of course, biology and genetics, which I was glad someone mentioned. So we can't do so much about changing that, but we can use it also as part of the framework for determining health. And why is determining health important? So this was just more of that, right? So, social factors, I forgot, living wages, transportation, safety, right? Safety becomes a big issue, right, when we're thinking about gun control at the moment after Parkland in Florida. This is what everyone's worried about because there's two sides of the coin, of course, but people are saying this impacts our health, right? The lack of public safety. Exposure to hazards. We want clean air, but if you've driven on I-4 like I did this morning, I'm sure you were sitting there going, oh my gosh, what's going on with our air quality? My in-laws live in Southern California, right? And very expensive place. 15 years ago when I first got married, you couldn't see the mountains from my in-laws' home in Southern California. There was that much smog. But because they've put very strict regulations on a whole variety of things, the air quality is actually a lot better in LA for the most part, and it's actually better than many other cities that we'd think about. Health services, right? Availability. Cost is a big issue, right? So cost is a determinant for why we don't get preventive care. Insurance issues, lack of coverage for the most part. Is a lot of things that should be covered really covered or not? Language becomes an issue, and this results in unmet health needs, delays in care, inability to get preventive services. You get the point. And then, of course, individual behaviors that we talked about, and then biology and genetics. So what causes the most morbidity and mortality in the U.S.? It's still cardiovascular disease for the most part, but then tobacco, high blood sugar, physical inactivity, obesity, high cholesterol, da-da-da. You can see this list. What's interesting about this list is all of this is something we can deal with, right? It's just something we don't deal with well, right? Because there's nothing here that's not necessarily treatable for the most part, or where you couldn't put in some mechanism in one of the determinants of health to address this, whether it's alcohol use, whether it's unsafe sex, right? That might be a policy-making education type of thing. You know, low fruit and vegetable intake. There's a lot of things that we can address. So this gets us back to, once again, now we're focusing on the individual. Are we healthy, and how do we know we're healthy? And this becomes very important in kind of the older population, right? So younger, older, and healthcare costs, and I think everyone knows this. So someone over here uses very few healthcare dollars, right? And actually Medicare is dependent on there being a big population over here to subsidize those over here. So if you're not aware, you know, more than 80% of costs is generated by a small percent of the population, but actually more than 80% of healthcare costs come like within the last month of life, right? And so our goal here is let's try not to move this spectrum. So let's hope that just because you age, maybe we should try to, as we age, keep people in this healthy low-risk group, right? Is there, I mean, do they have to transition up here? So that's the fundamental question. So is it a given just because you get old that you're going to develop chronic disease and develop hypertension, diabetes? No, it's not. Sometimes it may be biology and genetics, so you can't do much about it, right? But our goal for everyone is to keep people at the lowest risk level for the most part. And as we know, the healthcare system doesn't do this well. Why? Because our healthcare system is focused on being reactive, right? We wait for the disease and then we figure out optimal ways to treat it, and we put all of our money and resources to being reactive and very little to being preventive, right, on this side. Most of the people over here that are quote unquote healthy probably haven't seen a doctor, right? Because there's no need to, there's no need to get a physical, no need to get anything. But at the same time, then you're missing out on identifying those that are at risk, right? Because that's where we started this conversation. How do you know you're healthy? How do you know you're at risk or not? And so how is prevention currently done? Because this is the fundamental problem in closing healthcare gaps, right? So does anyone disagree that prevention is the best solution, or maybe not the best, but is part of the solution, that we should be focused on prevention? I've never met anyone that's disagreed with that statement, that prevention is a bad thing for the most part. Maybe some anti-vaxxers might think that, but outside of that group, I think everyone would agree prevention is. So what's the problem with prevention? So Americans use preventive service about half the recommended rate. This is very different, right? If you go to Norway, if you go to Sweden, if you go to those countries that once again have healthy communities and tend to be up there on the happiness quotient, they use preventive services at like 90, 95% of the rate. So we do very little for the most part. Once again, cost sharing reduces the likelihood of preventive services, right? And what's that cost sharing mean? It just means there's a copay, right? Or maybe you have a high deductible plan or whatever it is. So because you're feeling healthy, you're absent of pain, you probably don't go to the doctor because you're like, that's a waste of $50 or $30 or whatever, and I could take the kids to a movie for that, right? And so that is one of the limiting factors to doing prevention. Who's at risk? We already know this. So chronic diseases cause 7 out of 10 deaths and are responsible for a lot of our financial expenditure, right? But the opportunities for prevention impact all of us regardless of age and regardless of perceived health status. Because like I said, fundamentally there's a flaw. We don't know that we're healthy, right? You have no real basis of telling me that you're healthy for the most part. You might have some genetic data that says, yeah, my risk is less, but you know, just because you are absent of disease doesn't necessarily mean you're healthy and that you won't develop disease. And so we need to really invest in prevention, okay? So the bottom line, and this is not my bottom line, this is well defined by lots of scientific studies and a big study done by the CDC. What we need to do is eliminate cost sharing for preventive services, right? And that's been well established. If you get rid of the copay for mammograms, women get mammograms at like twice the rate. We need to focus on preventing disease before it starts. A lot of that is, once again, getting to those determinants of health and making sure we put in the systems for access, for everything else. We need to do a lot of counseling on preventive health topics, like quitting smoking, eating better, losing weight. When was the last time your doctor actually talked to you about that? You can't, and I practice medicine. I know you can't, because the paradigm of the way medicine is practiced is you have 15 minutes with the patient, and of that I have to spend about 8 minutes documenting what the hell I'm doing so I can get reimbursed for it. So that really means I have 2 minutes to ask you anything, and then like another 2 or 3 minutes to tell you something. It's impossible for me to even ascertain what your diet is like or ascertain what your exercise regimen is like and to give you any fundamental real feedback on it. Right? I mean, the programs that we know that work at people losing weight, let's say. Let's take a Jenny Craig. I mean, Jenny Craig doesn't do anything spectacular, right? They got like a point system. It's a color-coded thing. But what they do is they spend time telling you how to use this, right? It's nothing that's fundamentally groundbreaking in terms of technology. It's like assign points to this, add them up, and be below this. I mean, it's not that hard of a thing. But having one-to-one FaceTime with someone that tells you about this and how to do it is what there's no reason a doctor couldn't do that, except the paradigm of medicine prevents us from doing that. Vaccines, we need to really counsel about screening, make sure people do have wellness visits, right? So this is part of cost sharing. So the reason we don't have wellness visits is because you only want to go to the doctor once. So instead of going there for the wellness visit, you like to throw in that, oh, by the way, I've got this pain here, I've got this pain here. So that fundamentally changes the nature of that interaction, because it then becomes a disease-focused thing, and it has to be from the medical billing part. So once again, it's the paradigm of how we practice that instead of using the wellness code, I have to use a different code for it, and so that changes why things don't happen. And then we need to identify and aggressively manage chronic disease. I told you those things that cause morbidity and mortality, and like high blood pressure is still a huge issue. And if you look, right, in the US, patients identified with high blood pressure actually have about a 50% chance of actually having that blood pressure within targets. Once again, if you look at places that do this well, the number is around 80 to 90%. Now, I've been to Norway. I don't think Norwegians are smarter than I am. So fundamentally, there's got to be a problem with the process rather than individual behavior. So, but these are all challenges, right, that the CDC has identified. And so how can we address those challenges? So in order to do that, you need a framework for doing a good health risk assessment, right? Whether you're a young patient, old patient, you got to do some type of health risk assessment so you know what the gaps are, right? To figure out what needs to be done from the prevention, what counseling needs to be done, what are all the areas that need to be addressed. And so the CDC, once again, did this and said, okay, if we're going to do a health risk assessment, what needs to happen? So it needs to have a balance, it needs to be comprehensive for the most part. You have to focus on really high priority questions. So, do you eat avocados every day? Doesn't cut it, but much more focused on what the overall diet is. Used to be and needs to be person-centered and culturally appropriate, yeah, all this. Use a shared decision-making process, and then really offer training to healthcare providers, and then offer action-oriented information, blah, you'll see it. So unfortunately, this is something that doctors don't do well unless you have a tool or a system to implement this. And so this is where the solution comes in. So I'm the medical director, as I mentioned to you, of a company called Welltality Health, based out of Jacksonville, Florida. This is a company that was started by a student that I worked with in the Masters of Healthcare Administration program at UF. So he came to me and we were talking about business development. That was part of one of the classes. And he was like, well, how do we, and he's a young guy with no healthcare issues, but he was like, how do we make prevention better? How do we do prevention better? And so to make a long story short, this company was formed with this concept of doing very good health risk assessments, right? And so the way, but of course, if you create a company, you got to figure out a way to monetize it. So we're a health risk assessment company that essentially focuses on the annual wellness exam. Is everyone familiar with the annual wellness exam? So Medicare, so once again, this is unfortunately not focused on younger patients, but Medicare pays for something called the annual wellness exam, because Medicare recognized, right, that the studies from the CDC and et cetera were very good and that we need to focus on preventive medicine. And so Medicare pays for this called annual wellness exams. There's no copay, right? So it goes back to that, there's no cost-sharing component to the patient. And the goal of this is to really do a very good health risk assessment to identify the gaps, to find what the additional preventive services need to be, to find what the behavior changes need to be counseled to essentially move that patient back into a framework of health and things that impact long-term health outcomes. So Medicare began reimbursing physicians for this back in 2011. But interestingly enough, if you look at the Medicare population, 82% of them did not receive an annual wellness exam, right? So forget the young patients on that spectrum, right? The ones with the chronic disease where we need to identify the healthcare gaps, 82% of them actually didn't have any assessment of what that is. So, and there's a lot of reasons for that. But once again, it's because this is a very comprehensive process. So Medicare says if you want to do a wellness exam, you actually do have to ask about diet. You have to ask about exercise. You got to know something about their safety, right? And safety in the home and fall risk. You have to do a depression screen. So once again, that's a lot of time and energy, right? For me as a physician, where I can be like, I can just, talk to them about their hypertension, bill this code, and then I'm done. So unfortunately, once again, the paradigm of how medicine is practiced is what limits this annual wellness exam. So that was the challenge that we had to come up with. Well, how do we do this? So the underlying problems was for medical practices is scheduling those patients, talking to the patients so they understand the benefits of this healthcare risk assessment, right? So if you talk to patients, they don't quite get, like, why am I having a wellness exam? I just saw my doctor, right? So it's really educating that the goal of this is to identify the healthcare gaps, to identify the other areas, and that there's no cost to them, and then applying pretty consistent standards doing it. So if we look in Florida, once again, very low usage in Florida, which is kind of a shame, right? Because we're the fourth most populous state in the country, and we have a fair number of retirees or Medicare population in Florida. I think everyone would agree with that, right? All those silver alerts probably give that away. So, I mean, this is, really frightening that we have this tool at no cost, or we have this mechanism that Medicare has identified as a way of improving people's health, and we don't do it. So Welltality aims to correct that, and our clients do that about 70 to 90%. Once again, the wellness exam goes through a lot of things. So self-assessment of health, psychosocial risk, behavioral risk, things associated with functional status and their activities of daily living, medical family history, So we make it easy. Let me show you how we do it. I think this is probably the best slide. So essentially, we work with physicians' offices, right? So we go to a physician office, and then we contact them, and we say, tell us who your Medicare eligible patients are. Or just give us a list of your Medicare patients, and we'll do the eligibility check to determine if they've had this done or not. And then we gather preliminary information on the patient in advance so we know it. And then we arrange to schedule them. So we talk to the doctor's office and say, give us one room for X day, whatever day you pick it. And then we've scheduled 10 or 12 of your patients for that day, for that room. And then we bring a medical assistant there, essentially to complete these annual wellness exams. The way we do this, though, is we don't just go through a checklist for the most part, because as you can imagine, and this is the way actually a lot of doctors do it, because some of the EHRs have checklists built in, but checklists aren't very good for the most part, because they're meant for you to just click, 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 without really identifying what the needs are. So what Welltality has done is we built a software platform where there's an algorithmic process to it. So for example, when you, as the MA is asking you, if you enter diabetes, let's say, or she asked about your diabetes, and the answer is yes, then all the appropriate recommendations for a diabetic are defined that we can then determine what's there or not. Like, have they had the hemoglobin A1C? Have they had the eye exam? Have they had these? And then so we end up going down this decision-making tree, all software-based, or MA can do this. So based on the input questions, essentially there's algorithms to make sure all the appropriate follow-ups, recommendations, vaccines, et cetera, have been performed and done. So my job as medical director is I develop those algorithms. So I spent time, like for example, let's take COPD. I looked at the guidelines from the United States Preventive Service Task Force. I looked at the guidelines from the American Heart Association. I looked at guidelines from the American Society of Thoracic Surgeons, and then put those together into a best practice. So if you answered COPD, essentially there's a whole list of other things that need to be addressed, and we can now identify if they've been addressed based on the patient information and the medical record. And so ultimately what happens is you get a personalized preventive care plan, and there's two of these. You get one that's physician-focused, meaning the doctor gets this, and then one that's patient-focused. And this is like a big report, and I think Ellen has these, but like here's an example of a report. And it's, you know, I don't know if this is the patient one or not, but it's color-coded, and it tells you, like in this one, the first category is nutrition, and it's identified that this person has a health risk, and it gives the appropriate recommendations and follow-ups in terms of what should be done. And that may be referral to a nutritionist, for example, for a patient with a COPD or a diabetic that, for example, is still not under control. It has exercise, blood pressure, vaccinations, right? Like this person comes in yellow, so there's room for improvement. It's because they're haven't gotten their shingles vaccine even though they're eligible. So part of this, the software defines what you're eligible for and what you've received or not. And then it also gives you, so it goes through various different categories. So bone health, tobacco, alcohol, cancer prevention, daily living, cognition, advanced directives, so everything that's required by Medicare. And then, once again, it gives you personalized recommendations in each of these categories for what should be done. So, for example, this person on diet had very low vegetable consumption. They had reported really 0 servings per day. And then there's, not only is there a recommendation, but we provide educational materials for the most part. It also devises a 5-year plan for what needs to happen. So, for example, in this patient in year 1, because they don't meet criteria, they should actually get referred to an endocrinologist for their diabetes. They need to lose about 10 pounds of weight. They need to consult with a physician about chronic care management. They need to have a screening for audiometry for the most part because they identified hearing loss. So you can see kind of the advantage of this. So this identifies the healthcare gaps that are associated in that patient with Medicare, which is, once again, those patients with chronic care issues. And then it makes it very easy because now the physician essentially has a guideline of what needs to be done and what needs to be ordered and has a blueprint or a framework for moving forward with the care of that patient. It's also advantageous to the physician because now as we get the quality care management mechanisms of getting reimbursed, right? You only get reimbursed if a certain number of your patients are healthy and you meet certain criteria. So this identifies all the gaps in your patients, so you can say, oh, wow, I didn't realize about 50% of my patients don't get flu shots, so I got to do something about that. You know, I have, 30% of my patients didn't get a hemoglobin A1C in the last year who are eligible, so I need to address that. So it allows physicians to implement systems in place, all for the purpose of improving the care of the patient, but at the same time improving their quality of care and allowing them to meet some of the HEDIS measures and some of the other quality of care measures. So in the system, we can do about 12 to 15 wellness exams per day. Physicians bill for these, right? So the way the guidelines are written, even though our medical assistant is doing them, they're doing them in your office, and you get documentation of what's happening, so you can bill this. And so the Medicare wellness exam reimburses between $165 to $179. So for most physicians, that's easy. You don't do any work. You got a way to improve your patient's health, and you got a way of generating revenue, as well as closing care gaps and improved patient care. Interestingly enough, when you do this, you identify a whole bunch of gaps that result in ancillary visits, right? So because you identify that Medicare will pay for a follow-up visit for you really to talk about nutrition, or Medicare will pay for a follow-up visit to talk about that abnormal lab test result. So when you do this correctly, you actually end up getting recommendations that require about 4 appropriate follow-ups. So our goal isn't just to bring people back to make more money, but to make sure they come back to close those healthcare gaps. So we often identify a minimum of often 4 ancillary visits that are required to close those gaps. Well, those visits all result in reimbursement. So by doing an annual wellness exam at really no cost or very little cost to the physician, you end up generating quite a lot of revenue for that practice when implemented appropriately with the initial visit as well as the subsequent follow-up visits. So this is a very good way of essentially closing the gaps for that Medicare population. So it's a very good health risk assessment tool to give you a disease risk assessment to help you close gaps. Okay, so that's essentially what I wanted to say about Welltality Health and the way of closing gaps in this Medicare population. Now I'm going to move into how do we implement precision medicine and what's the future going on. And this is kind of where this gentleman brought up, what is the role of genetics in it, right? Because a lot of the initial healthcare assessment is based on the questions you answer. How often do you exercise? How often you do whatever you do? But as we know, as you point out correctly, you might have good genes which have a certain basis. Because for any disease, there's an interplay between genetics and environment, right? So the guy who was the trainer for The Biggest Loser, right from the environmental side, he was probably doing everything correctly. But he just had poor genes, right, that contributed to him having an early cardiovascular event. So there is an important role of genetics in this. And so how can we utilize genetics for this? So this is where this concept of precision medicine comes in. So precision medicine is essentially an emerging approach for disease treatment which takes into consideration individual variability. Right? To say, you are actually very different from me, right? So even though we may be very similar from everything else, we could even live in the same household. We could live in the same community, right? We have access to the same publics and the same resources, et cetera, but there's clearly variations in our health. So how do we account for individual variability in the care and management of patients? This is a fundamental problem because the way the paradigm of medicine, once again, is practiced, if you come to me for high blood pressure treatment, right, there are some guidelines on how to treat blood pressure, but it's really, at my own recognizance, what I can order. Right? And oftentimes that's dependent on what pharmaceutical company has given me a lot of pens, and so I remember the dosing. Now it's not that important because of EHRs, but in the old days, that's really why I picked, Biaxin versus something else, because you had the paper chart, and I had enough pens that said, clarithromycin, 100 milligrams twice a day, that I remembered it. So it was like, oh, what am I going to use? I have these 2 choices, but I remember the dosing on this one. I don't have to look it up. I mean, it was smart on those. But the point is, it's not based on you as an individual, right? That's based on just my general consideration of what I should order. And so we need to move to the point where we're considering individual variability so we can personalize or tailor medical treatment. And so the practice of medicine has now entered an area where the individual's patient genome will help determine the optimal approach to care. This is very relevant, for example, in cancer for the most part, right? So cancer is the area this has really come in the forefront, because based on the molecular signature of the cancer, you're picking the treatment appropriately. So 20 years ago, if you had lung cancer, we treated you with, let's say, CHOP, and pretty much that was first line. Everyone got CHOP. Now, what we do is we actually do molecular analysis on the cancer, and then we pick a drug that's tailored to that molecular alteration, right? So this is precision medicine. So it's been happening in the oncology field for the last, I'd say, almost a decade, but it's starting to happen in other areas. So the goal of personalized medicine is the right dose, the right drug, the right indication for the right patient at the right time. So it's not me just saying, I'm going to treat you with this hypertension drug, because it turns out that about 30% of people either don't respond to it or have side effects from it. So wouldn't it be better, instead of doing that, if I knew, or at least I had a probability assessment to pick the correct drug for you in advance of doing it, right? So that's kind of the goal of precision medicine. So this is my other company that I own, GenomeGyde. It's a molecular diagnostics company based out of the biotech incubator up in Gainesville. Without going into great detail, one of the things that we've done is we use a lot of robots to essentially provide comprehensive genetic testing at very low cost with high quality. So this is really kind of the future, and then I'll talk a little bit about the advanced AI and bioinformatics. So I think pharmacogenetics, most everyone has probably heard of. This has been in the news a lot. This is the next kind of bread and butter implementation of genomic medicine. And so if we take this group, let's say we take this group here, and let's say everyone has the exact same diagnosis of hypertension, right? If we treated everyone here with the exact same drug, obviously there's going to be some people where the drug is toxic and not beneficial, others where the drug isn't toxic but still didn't respond to it, then where the drug is toxic and not beneficial at all, and then here's the group where the drug isn't toxic and actually beneficial. So we hope everyone's here, but the reality is there's a lot of people over here. Why does this become a problem? Because this is what results in polypharmacy, right? If you've actually talked to any doctor, this is one of the reasons you have to have the MA in front do a medication reconciliation for all your patients. And it takes them 20 minutes, because once you start asking what medication you're on, there's a list of like 8, 10, 12 things, right? Like that's, I don't know where we got to the where we're now treating everyone with 10, 12 drugs for the most part. And not to say that they're not appropriate. In some cases, they may be appropriate. But when I was a much younger man when I first started in medicine, most of my elderly patients were usually on 1, 2 drugs, right? If I looked at my practice parameters when I left medicine, most Medicare patients are on an average of 7 drugs. Right? And so a lot of that is because what happens? You get a drug, it's not effective, so you have a choice. You change the dosing or you add another drug. But once again, time is the limitation, right? So it's hard to explain to someone the pharmacokinetics of a drug, how they should take it, when they should take it, what they should look for. It's easier to say, here's another script, add this to it. And this is why our elderly patients have more polypharmacy than any other country in the world, right? If you look at even elderly people in India, China, et cetera, very few medications, right? So you need the correct medications to do what you need to do, because it's all about risk adjustment, right? We don't want people to die of hypertensive disease, but picking the right drug is often difficult. So doing pharmacogenetics in advance allows you to figure that out. And why is that? Because 92% of drugs are cleared by the liver, and they go through this one system called the CYP450 system. So if you test this system, right, and I know which genes in this system and how those genes operate, for the rest of your life, any drug you give me, I can tell you how you're going to metabolize it. So the thing is, if you're a fast metabolizer, what does that mean? It means that drug goes through your system really quickly, right? So what's going to happen if it goes through your system really quickly? Yeah, it'll be effective for a period of time, but then it won't be. So your blood pressure may be controlled in the morning, but not later on. And so that's a drug that you might need a higher dosing, or need to change to twice-a-day dosing or 3 times a day dosing, right? What about if you're a slow metabolizer? Well, if you're a slow metabolizer, the drug stays in your system too long, right? So think about that for some of the diabetic medications. So it stays in your system too long, and what happens? You forget to eat, you're traveling, right? Your blood sugar bombs, and then you end up in the hospital for that reason. So testing the system is an easy way to really optimize drug therapy. So this is an area that there's a lot of data in psychiatry. So in psychiatry, treating various psychiatric diseases, there's a lot of polypharmacy. So it's very difficult to treat bipolar disorder or any other psychiatric disorder with monotherapy, meaning one drug. And so patients get on 3, 4, 5 drugs. But the problem is, you know, you're not the same person at the end of this, right? Because all those drugs interact and have issues. Using pharmacogenetics, it's been shown that you can optimize that therapy, and so oftentimes you can manage the same disease to the same degree of control with much fewer drugs. And once again, the system works for pretty much every class of drug, because most drugs go through that. And the advantages are its ability to make more informed decisions, right? So now when you see that patient, you don't necessarily just have to add a new drug. You know a little bit about it, so you can say, you know what, we probably just need to increase the dosing and we'll get the right effect because you're a fast metabolizer. Higher probability of desired outcome, right? This is also an issue because what happens, the patient comes to the doctor for blood pressure management, they're given a medication, they get side effects, blood pressure isn't controlled, so they're like, well, I'm going to spend $30 to go back to that doctor. And so what happens? They either don't go back to that doctor at all, or they find a different doctor, but then there's lack of information, and so the process starts again. And so this patient has their blood pressure unmanaged for 2, 3, 4 years, accumulating, you know, kidney disease, eye disease, et cetera, all because there wasn't appropriate time to communicate and treat appropriately. Earlier disease intervention is possible, and then there's a decreased chance of hospitalization. So it's the right drug for the right patient at the right dose. Now the next area where pharmacogenetics or genomic medicine is coming to play, and this is the area we're really getting into, is nutrigenomics, right? So how many people have been on like an Atkins diet? Anyone? How about a low carb? A lot of people, low fat, right? So do any of them work? Maybe? A little bit? Yeah. So that's a problem, right? None of these diets work. Why don't they work? Because of the tremendous variability of the people in this room, right? Our diets are very different. You know, I'm of an Indian background. What I eat on a daily basis is probably very different from what you eat on a daily basis. So there's cultural issues, and then et cetera. So the problem is when we had the kind of the RDA, you should have 55% carbs, et cetera. What is that based on, right? It's actually, if you know the data, it's based on a bunch of farm boys in Iowa, right? And the last I checked, I'm not getting up at 5:30 in the morning to get eggs and then work my ass off in the field, right? So my current lifestyle does not hold for that. This is why those caloric requirements are tremendously wrong. Like if I put in on many of these things, it tells me that I should have a caloric intake of like 2,700 calories or something per day. That's ridiculous for someone of my size and frame. So all of that is based on these very broad general guidelines that aren't really valid anymore because of the tremendous variability in individuals. How many people know individuals that eat as much as they can but stay skinny as possible, right? And then others eat very little and still get the beer gut. Well, this is due to beer, but you see what I mean? That's because of the variability in how we process things. So this is where nutrigenomics comes in, because once again, your genes can help identify how you metabolize, what you metabolize, when. So the reason that some of those diets work only for a short period of time is you may have genes that predilect you to a high protein diet, meaning you do well with proteins, but not so well in carbs, all right? Or it could be the complete reverse for the most part. So you can actually do some nutrigenomic testing. So we have a panel of tests, and we didn't make this up, by the way. So this is all data that came out with the Stanford Nurses study. So if you're familiar with it, you're probably familiar with the Framingham study. So the Framingham study was a study started in like the 1940s in Framingham, Massachusetts, where we decided to see essentially, what happens to people? Like, how do we figure out health? That was a real fundamental question. And so the Framingham study, they took a bunch of men in Framingham, Massachusetts, and they just followed them for like 20 years just to see what happened to them. And interesting enough, that's a study that identified cholesterol as a risk factor for heart disease, because it turned out that, you know, you're just watching these men over 20 years, a bunch of them died of heart attacks, and then someone said, hey, there was a correlation, you know, when we looked at all their blood tests, the ones with high cholesterol tended to die of heart disease. And so it was following men over a period of time that they came up with what the risk factors were. So of course, it took, you know, 30 plus, 40 plus years, and then women got into the game, or at least we got smart and said, you know what, maybe women aren't men, and so the data we have on men isn't necessarily applicable. So they started this study in women where they followed 40,000 nurses over a period of 15, 18 years, once again to see how they did. So there's a lot of medical information of that, but nurses representing the typical American population, just like everyone here, also went on Atkins, and they went on South Beach, and they went on low carb and high fat, and they went on everything else. And so in this study, they actually had genetics done so they could find correlations to say, well, which women lost weight on what diet based on what genetics, and they came up with this. So anyway, to make a long story short, we can test genes that tell you something about your eating behaviors and your predilections, for example, snacking and hunger. Why is that important? So if you've got a predilection for hunger, or you have a predilection for not being satiated with food, right, there are strategies you can use to address that. So these are, the satiety part is relatively easy. This is where drink a glass of water, eat an apple about 20, 30 minutes before your meal, right? Because odds are your meal is not going to make you feel full, and then you're going to be snacking 2 hours later. So how do we address that? How you metabolize alcohol, caffeine. Most importantly, it identifies nutritional needs for the most part. So how many people here take vitamins? Right? I do too. Did you know that there's no medical evidence at all that vitamins do anything? Like, there's never been a study that shows they actually decrease morbidity or mortality, etc. But we love to take vitamins, right? Because we feel that they're probably doing something, and they've got to be healthy for us. Well, now we can, you know, and we probably spend a lot of money. You know, those Centrum Silver aren't necessarily cheap. So we can actually determine what vitamins you might be at risk for needing, right, for the most part. And then most importantly, you know, we can tell something about your body and weight composition for the most part. How likely are you to lose weight based on a single diet at all? Identify what the matching diet is, what your response to fats are. And then importantly, we can do a lot, and this is all relatively new on the exercise standpoint, right? So once again, treadmills lie to us. If you and I ran on the treadmill for the exact same amount of time, it might say we lost, you know, we both lost 200 calories. The reality is that's very wrong, right? I might have actually lost 150, and she might have lost 200, right? So once again, those algorithms are based on a 70-kilogram white male in some place where the company is based that they came up with the algorithm, and that's not me. So we can actually tell you if you're more likely to have a better response to aerobic capacity or to endurance training, what your ability to lose fat with exercise is. That's actually an important one, right? Everyone always says, I just need to exercise more. No, sometimes that's not it. Just genetically, you're not someone who's going to lose fat because of exercise for the most part. Similarly, your blood pressure response to exercise. So this is an example of how clinicians can use this, right? So the American Heart Association says the first thing you do with someone with high blood pressure is you counsel lifestyle changes, and you say, you know, come back in a year, right? Well, if you know that they're not going to respond to the lifestyle changes, maybe you're better off starting medications earlier. I mean, it's always good still to try lifestyle, but you have to make that decision, right? And so how many patients, once again, are like, I don't want to take medications, I'm just going to go try to change it myself. But how many of them actually succeed? Those are questions that, you know, happen on an individual basis for the most part. HDL response to exercise. So HDL is one of the markers in your cholesterol panel. That's a risk factor for heart disease. Anyway, so you can, a lot of people take medications to make it go up, and a lot of people are like, oh, no, I need to do exercise. But so you can tell some of that. Anyway, our lab does comprehensive genetics from a whole variety of things, from cancer genetics, cardiovascular disorders, intellectual disability, pretty much any genetic test that's available, our lab can do for the most part. And then what we're moving to now is the way to do risk assessments, now doing something similar to what I talked about with Welltality, but now adding in the genetic component to it. So now having the genetics along with a comprehensive risk assessment essentially allows us to figure out a better biomarker testing strategy, right? So once again, absence of disease doesn't necessarily mean that you're healthy. But there may be tests that can give us some assessment of that, right? Most doctors don't even know about this. But I'll give you an example. CRP, many people have heard of C-reactive protein. It's an inflammatory biomarker that's actually a pretty good predictor for heart disease. Except there's a caveat to that. It's a pretty good predictor of heart disease in someone who's close to 50, not someone who's close to 40. It loses positive predictive value at that age. As you change, or based on what you have, there are other biomarkers that may be more or less predictive of health. But the problem is, you don't know what they are. Most doctors aren't educated in terms of what they are and what the optimal strategy for the most part. And I'll tell you, as a physician or as a clinician, I don't know that either, right? So getting all that information, there's a lot of data. But once again, the sensitivity and specificity, all these biomarkers changes based on the cutoff and where they are. I don't know what the optimal one is for you. But this is where we're starting to use bioinformatics and machine learning to put it together. So I don't know if this is going to go. So I gave a talk on precision medicine for the governor of Wyoming as part of the Wyoming Economic Conference. And what I wanted to show you is that the power of AI, or artificial learning. This is a robot that essentially walks, right, which is fine, but if you destroy one of its legs, right, what happens? It goes in a circle, except this is a smart robot. So what it does is it actually tests different hypotheses and learns from it, and this robot took all of 22 seconds to figure out how to walk in a straight line with a broken leg, for the most part. If you read recently, you know, the World Championship Go player was defeated by AI. Just last month, there was a AI built in Europe that beat a chess grandmaster. But this is what's interesting, is they actually didn't teach it how to play chess. They actually just gave it the rules of chess and let it play itself. And essentially, it played itself only for about 3 hours before it beat a grandmaster in chess. So starting that. So we're starting to put some of those same algorithms in play for this wealth of medical information. So if you have that risk assessment, once again, that's a lot of information. Finding the optimal way to deal with that is the difficult part. And so what we're doing is taking all that, you know, everything in the history, the records, the exam, the diagnosis, the results that you have, the prescriptions you have, adding the genetic component to it, putting in a comprehensive risk assessment so we can close those healthcare gaps. And more importantly, we can give you a better prediction of your health, right? We can identify, well, you know, we're not sure if your 5-year risk of heart disease is 5% or 8% or 10%. And that may make a big difference to you. But we can now identify, well, maybe you should have this test that will help us narrow that down. Because you might make different plans in life if you have a 10% 5-year risk for a stroke versus a 2% risk for stroke. Anyway, that's, I think, my last slide, where, once again, talking about new ways to optimize health. So all this other stuff on the genetic side is a little bit futuristic. That's to come. I mean, we do the genetic testing now. We're working on the bioinformatics piece now, so we can do that genetic testing to help clarify risk. Welltality Health has been in place for about 2 years, and I think we've run through more than 50,000 of these annual wellness exams in North Florida, with tremendous impact on the patient population and on the care providers who have realized the benefit of having someone come do this comprehensive health risk assessment in their office. And we're using the mechanisms in play with Medicare, so there's really no cost to the physician and no cost to the physician, and so it's a win-win for everyone. So thank you very much for your time and attention. I'm sorry I kind of went over a bit,
okay.
and I'm happy to answer questions.
Yes, great presentation. Thank you, Dr. Shah. We are running a little late, so we'll just take a couple of questions. I think that Celia had one that Chuck had mentioned, so we'll get that on tape.
You mentioned twice in your presentation attention to cultural attention with diet, nutrition, and changes, and your diet is going to be different from somebody else's. Are you aware of anything that is currently out there that would help a physician be able to make those recommendations, since we're such a melting pot? It's frustrating to and disappointing for everybody involved when you recommend that they, have 5 vegetables on their plate and so on and so forth, the balanced diet, when they come from a culture that's not been, those foods have never been part of their culture.
Yeah, so it's a great question. I was actually talking to the dietetics department at University of North Florida just last week. The answer is actually probably a referral to a dietitian. So dietitians and nutritionists have these tools that physicians don't, for the most part, to make or come up with culturally appropriate diets. So my wife, for example, is from South India. My mother-in-law has diabetes. Well, the South Indian diet is 95% carbs, right? They're vegetarian. I mean, they have virtually no protein at all. But that's okay. South Indians have been eating this diet for, thousands upon thousands of years. So you can't just go in there and say, change this. You got to do it within an appropriate mechanism. And so they're out in California. So Kaiser actually has nutritionists who are trained across different dietary spectrums. But I think most professional dietitians will have the tools to do that.
Martin?
Could you tell us a little bit about the role of antioxidants in prevention?
Oh, that's a big question in that. Yes, I can tell you a lot about the role of antioxidants in healthcare prevention. So, number one, there's no good medical evidence that antioxidants do anything, okay? Having said that, though, there's a caveat to this. So you have to always be careful when I say stuff like this in terms of study. So the concept of antioxidants you have to go down to the cellular level. So at the cellular level, you have something called mitochondrial respiration. If that doesn't go appropriately, you end up with what are called these free radicals, and free radicals are extremely damaging to the cell. Antioxidants at the cellular level actually do a lot of good things in terms of preventing cell damage. It's just never been shown that you can get an antioxidant or antioxidant levels by taking some antioxidant pill or blueberries or whatever to actually have antioxidant effect at the cellular level. That's the fundamental problem. So yes, if we could get antioxidant effect at the cellular level, probably would be very effective. The question is how to do that and what can do that very well. Now a lot of people are into measuring nitric oxide and et cetera. The problem with a lot of those measurements is nitric oxide has a half-life of like microseconds, right? So what are you really measuring? Because that level might be very different a minute later, right? It might be impacted by the fact that I just had orange juice and there's residual effects. So the problem is, one, in appropriately addressing what is going on and then coming up with that. Having said that, a lot of people believe in the antioxidants, and maybe there's some truth to it. So I won't say that there's no benefit to it.
Well, I thank you for the very informative talk today. I know that we're running a little late, so we're going to cut the questions short for now for those that need to respect their time this morning. But thank you so much for joining us at Medical Office Resources of Florida.